This episode of To The Point is sponsored by Tarsus. Tarsus Pharmaceuticals applies proven science and new technology to revolutionize treatment for patients, starting with eye care. Tarsus is advancing its pipeline to address several diseases with high unmet need across a range of therapeutic categories, including eye care, dermatology, and infectious disease prevention. Tarsus is proud to announce that Xdemvy Lotilaner Ophthalmic Solution 0.25% is now available to prescribe.
Ocular surface disease. It's complex, chronic, and progressive, but rife with opportunity for the enterprising optometrist.
The mission of this podcast is to make this condition more understandable and accessible to those interested in specializing in it. So let's get to the point. Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I'm joined by my co-host Leslie Odell. And we are very excited to have our friend and fellow intrepid colleague on with us, Dr. Mark Schaeffer. So Dr. Schaeffer serves as clinical excellence captain at My Eye Doctor in Birmingham, Alabama, where he practices full scope optometry. In addition to his clinical work, he is affiliated with several pharmaceutical companies in consulting for ocular disease and contact lenses. He writes for multiple journals on patient care and in the optometric industry. Dr. Schaeffer is a founding member of the Intrepid Eye Society and is a member of the Alabama and American Optometric Association, the American Academy of Optometry, and the Contact Lens and Cornea section. Dr. Schaeffer earned his Bachelor of Business Administration and Marketing from the University of Georgia, his Doctor of Optometry from SCO, and completed a residency in ocular disease at Bascom Palmer Eye Institute in Miami, Florida. Hello, Mark. Thank you so much for joining us.
Thank you so much for having me. I'm so excited to be a part of this. I've been listening to you guys for a while, so I get to fanboy out a little bit while I'm on the podcast.
When I texted you about being on this podcast, the text went something like, "Hey, Mark, how much do you think you know about makeup on a scale of 1 to 10? And you said 2, meaning I don't know a lot about makeup. And I was like, perfect. You're going to be on this podcast because the goal of this podcast today is we're talking about makeup, what our patients do with makeup, the role of cosmetics and dry eye. And we really want to get someone who feels not super confident about talking about makeup and will ask the questions that we think people should know and know how to answer and how to talk about cosmetics with their patients. So we thought we'd maybe start out a little bit like, how do you start the topic or the conversation about makeup with patients when you see they are wearing a lot of makeup?
Actually, before he answers, I want to ask one other quick question, which is, what do you think eye makeup is? Or what do you think makeup is when you're thinking about
Wow. It depends on what your definition of the word is. Is this what we're getting at here? Yeah, anything around the eye and adnexa is going to be eye makeup, right? Anything that can be added, whether that's foundation, mascara, eyeliner, eyeshadow, anything, everything that touches the surface. It's like the Lion King. Anything that the light touches belongs to us.
So I'm already going to say you know way more than some other people who maybe don't even know what the word eyeliner means. So maybe you're not giving yourself enough credit. But my point of asking you that was to see if you knew what things were called, because believe it or not, sometimes people don't know the difference between eyeliner or eyeshadow, especially if they don't have, exposure to eye makeup. But a couple things that sometimes we don't think about when we go into this conversation is it really affects everyone that we come in contact with, because facial cleansers and toners or lotions that might be going on around the eyes also fall into this eye cosmetics.
Oh, I definitely agree. Cosmetics, right? You always ask. I like when I have patients, and especially those who are suffering from dry eye disease, they always have something that comes back to, there was one point I used to be able to wear eye makeup and now I can't, or I used to be able to wear X and now I can't, or I've had to stop wearing that. And that's a enormous red flag that shows up in the eye exam itself. But usually, to answer Jackie's question, like, it's always fun for me because I get the irony, right? Like, I'm a 39-year-old male doctor trying to explain to women about eye makeup. And that is the first thing that I say is I take the slit lamp away and I'm like, okay, I get it, right? Here we're going to talk about eye makeup. I get it, right? Like, I want to diffuse it as much as possible that, like, listen, I'm not here to tell you no eye makeup. And literally, this is what I tell every patient is because if I told you no eye makeup, I'd be the last female patient. You'd be the last female patient that I see. Or you're going to go, that doctor doesn't know what he's talking about. I'm just going to keep doing what I'm doing. So it's a way for me to immediately diffuse the situation and get past the awkwardness of I'm a male doctor trying to explain to a female patient how to take care of her eyes, which she's been doing for 20 more years than I've been in practice, right? And even some male patients, 20 years longer than I've been in practice, they're doing this on a day-to-day basis. So I try to diffuse it and build that bridge so that we can get to a better place of healing, essentially.
I think that's a great idea, actually, to start it out like that. And I really do like that you're saying, like, I'm not saying that you can't wear makeup because that would be a huge problem. Like, I mean, I say that to my patients too. Like, I'm not saying don't wear makeup. I still wear makeup. Like, I'm just saying there's a safer way to be doing this. And so I think that's a great lead in to your conversation. Are you seeing a lot of patients with dry eye or contact lens intolerance that you feel is related to like makeup?
Oh, definitely. Every day I tend to see it. And my cotton tip applicators are probably my best weapon against this. In the actual show don't tell. So like I will just, hey, while you're looking up and I'm looking at the meibomian glands, I'll grab a cotton tip applicator and say, you're gonna feel me wipe along the edge of your eyelid. And that's it. And I do one quick swipe inside to outside on either side. And I make sure to rotate it so I get two different areas of makeup so I can show the patient so they can see it. The only person that has a problem is a presbyopic, emmetrope that can't see that up close, but they can see colors. So they can see that is where I'm removing it from. And then I'll tie it into if they're having contact lens intolerance or having dry eye disease, this is stuff that's getting into your eye. This is not supposed to be there.
So you're kind of teaching them about the waterline that way, I guess, and just meibomian glands. My other favorite way to use the cotton tip applicator is for the patient that you see a lot of makeup residue on their lid and lash, and I ask them when the last time they wore eye makeup was, and they'll say, "Oh, not, for 4 days prior to this exam." And I love to just show them how much is still there, even though they've cleaned it off in their minds.
Air quotes cleaned it off. All right. It's a wipe. I'm done.
That's actually a good point. I had a patient today who had a very similar situation where she was like, I didn't wear any makeup today because I knew I was coming here. And then I was like, oh, really? Because there's like this light, like really strong band of like old, you can tell when it's old, like an old
Mm-hmm.
liner that's like sitting on that lower lash line. But us talking about, or Mark, you talking about using a cotton swab to sort of like go along their waterline. Are you familiar with those terms of like waterline placement with mascara? And do you know like tight lining? Is this like normal things for you?
Yeah, so I use the word waterline, and I always, again, when I do this, I like to seem like a dumb person. So I will say, I'll pull down the lid and be like, you see this area? This is called the waterline. Now stop me if you know this, right? Like that is, I want you to stop me if you know this. I'm not trying to over explain because, again, I'm not doing the trends, right? I'm seeing the trends secondhand. I'm not on TikTok, thank goodness. I already have enough things killing my time. But I'm not like aggressively doing that. And I want to make sure that I come off as I'm here to take care of you. We can laugh about it. Golly gee shucks, like I'm here to take care of you, right? Like that's what I want to do and have a laugh while I'm doing it. And it really cuts the tension in what I'm about to say, which is we need to do better. And I think it kind of builds into that with the patient that they understand now that I'm looking at something specific and targeted and not just saying something for the sake of saying something. Like I'm actually addressing a problem.
I think it helps when you have photographs for sure. So if you have a slit lamp camera and can actually photograph some of this, but even if you don't, like using the cotton swab to wipe along their waterline and then showing a picture of like where these glands open, it like I feel like really hits a home for a lot of patients. They understand like, oh, when I just put my pencil right over top of that, I'm like, you're blocking all of those. But the same goes for the upper waterline, which is like tight lining is another phrase that's used for that. And that's when people are like lifting up that upper lid and really going at it on that, upper waterline. So I say those two words too, but I think I have had women who don't know what that water line is. So I think it's good that you say I pull my lower lid down and this is the water line here. I think that's actually very helpful with patients.
Sorry, I forget that this is a spoken medium and not a visual medium. So when I like pull down my lid on camera, no one sees that. I should describe that. But yeah, I think that it's important for us to demonstrate and show that. And again, when you have a patient that says, I didn't wear makeup in today, I'm like, oh, shoot, you should have, right? Like, if you want to, I want to see what you do on a day to day basis. Like, when patients come in and say, I shouldn't have worn makeup, that's when I say, thank you for doing that. Because now I get to see when you're not playing nice for the doctor. I actually get to see what your normal day to day looks like. And I think that's important too for us when we have a patient that's like, oh, I shouldn't have worn eye makeup, or oh, I didn't wear eye makeup because of that. It gives us kind of this false sense of hope that, like, oh, maybe they are taking care of that. But then those are the things that we don't see the 365 other days a year they're not in our clinic that affects how their eyes feel. And it's almost like we have plenty of stories between the three of us of patients who live their life and completely in risk factors of things that don't show up in an exam room, or behaviors that don't show up in an exam room that have tremendous impact in their day-to-day life.
Yeah, I think that's important to, a lot of times people avoid wearing the makeup in, and then if you don't think to ask them, you might not even know what they're doing, the other days out of the week that they're not seeing you. One of my old colleagues had a patient like that one time. She didn't have any eye makeup on, but when he pulled down her conjunctiva or pulled her lid away, he said it was just like filled with glitter from whatever eyeshadow she had been wearing, over the weekend prior to her exam.
At the Taylor Swift concert, right?
Probably. Yes. I even was wearing eyeliner, which is not something I typically do just because of that. Um, so what about your patients when they think that, these makeups irritate their eyes, right? Or they irritate their contacts or whatever it is that makes them start paying attention to their eyes. So then they start looking at ways to avoid it. One might be waterproof because if their eyes tear and things when they're wearing their makeup, or they're tight lining or water lining, funny how that makeup is moving like through the lid to the corner of their eye because the meibomian glands are trying to secrete. But then they start to do other trends, and you can't help but ignore this one because it's everywhere right now, which is the eyelash extensions. I had to laugh. I was traveling last week, and a lady in one of the rows ahead of me, we were getting ready to get off the plane, and her eyelashes were partly on and partly off. And so it just kind of made me laugh. But I feel like eyelash extensions have gotten larger and longer, and I don't even know, how some of these ladies keep their eyes open to function in the day. So, but sometimes they think they're doing themselves a favor, right? They're using that instead of mascara every day, or maybe they even turn to a tattoo eyeliner to take place of the regular eyeliner. I'm sure you come in contact with that. How do you identify it? Is it easy for you to see that tattoo eyeliner or false eyelashes, from your perspective, Mark?
If I can't see false eyelashes, I need an eye exam these days. Like, it really is. Like, if you don't notice it on a patient, like, I come in, I walk in the exam room, first thing I do is look at the patient, and I have staff members, and I'll be like, hey, did you notice this thing? And they were like, no. And I was like, did you look at the patient? Because like, it's so important for us. It gets so easy for us to get locked into the flow of the day and looking at the chart and looking at everything, the routing slip, the 9 things that are going on in the back of your head, whether that's in the practice or out of the practice, that when you walk in that room, like, I want to make eye contact. I want to see how they react, what they're doing, what they're up to. I'm also looking at what they're wearing on their face, on their head, on their body. Like, is there anything that I can connect to this patient with? And every time I see false eyelashes, like, it is like a tractor beam just straight to the eyelashes. You can't miss it. So yes, I'm seeing it. I always like to ask patients how often when I look in it, when I'm looking in the slit lamp, I'll look at the lashes and be like, so how often do you replace or change out your lashes? Because I want them not to be like, oh, they look false from distance, like me walking in the room. But when I'm looking under a slit lamp, like, you can't hide that, right? Like, the patient doesn't feel like they can hide these are false lashes. So I always ask, how do you keep them in? Is it glue? Is it, is it like threaded in? Is it permanent? Is it removable? How often are you removing it? And then how are you cleaning between it? And that's what I ask every patient while I'm in the slit lamp, just because it gives me the ability to ask that question without them feeling like they're being judged from face distance.
I do something very similar. I always ask in the slit lamp. I don't ask when I'm like just sitting there talking to them, because I feel the same. I don't want them to think like I'm like, oh God, these lashes are so obvious. But one thing that I see a lot of, and I'm constantly taking pictures of, is tons of blepharitis in these lash extensions. So you've got like 2 different ways you can go if you're trying to like put on some fake lashes. You can use the long strip and use glue that you're just applying, sometimes like where you would apply upper eyelid eyeliner. And then sometimes there's a new trend where you're putting the lashes almost underneath and on the upper waterline of the upper lid, which is, kind of an awful place to put that, obviously. And then you have this other lash extension where they're literally going to a salon and sitting for a long
Hours.
period of time.
Hours.
Yes, a long period of time with Mark, you can Google it, or you can Instagram this and just watch this process being done. But they're going to individual lashes and gluing on these little lashes to the patient's lash. Now, the problem with this is, well, first of all, they do look really good. Okay. So they do, when they're done in the right way, like in that crazy long, they do look really good. But the problem is that the person that has this lash extension doesn't want to touch their lashes. They don't want to clean them because they're just going to rip out all of these lashes. So that, I feel like, is the hardest part, to really have that conversation with the patient. And oftentimes they're getting a product at their lash salon. Like, they're going to get whatever foaming cleanser that's being recommended to them. Sometimes there are brushes. We Love Eyes actually has a whole section on their website on like little in-between brushes you can use to try to brush through some of that stuff. There's another little soft, gentle brush that you can use with the foaming cleanser to get on the lash line. I talk about this, and I usually try to relate to the patient and say, I know you really don't want to get in there and clean those lashes because you're going to want to, they're going to fall, you're going to pull off of there, but you really have to because the eye is like not looking good. But those are kind of like the 2 paths. But okay, so this is me talking a long time, but I do have a question for you guys, because today a patient actually asked me, she was saying, my dry eye has been getting worse. This is like her entry into the exam. Like, my dry eye has been getting a little bit worse and I didn't notice this bad before. And then like kind of at the end of the exam, she's like, I really want to get lash extensions. And I'm like, oh, like, I don't know, we got this dryness going, I'm talking all about it. She's like, well, what do you think is worse, lash extensions or those like glue on strip lashes? You know what I mean, Mark? Those like, it's like a strip like that. And I was like, I think lash extensions are worse, but I would love to hear what you guys would say to that question. Like, what's worse, a lash extension or the, strip lash with glue? I presume that the lash extension is worse because it just sits there for longer periods of time and you have to go back in for fills and they're never really removing everything and cleaning everything off. But what do you guys think to that answer?
I would ask why. like I know it's for beauty, but like, is this an everyday wear? Is this a weekend wear? Is this I just want to feel fancy wear? Like, are you doing this every single
I
day?
mean, I think this trend is not going away anytime soon, right? I've been talking about it for it feels like 5 years, and I feel like the number of people that are spending the money on it keep going up and up. I don't think we know. Both of them have the same risk with formaldehyde. Formaldehyde is in the glues, so that's a risk right there. I would have to argue what you were saying, Jackie, does make more sense because it's kind of like single use, right? But then if they reuse that same pair of lashes, that's where you'll probably run into the problem. But these individual glued lashes pose a big risk because the eyelid is never getting a break. The people that are doing those type of extensions, just like you said, are back in every couple of weeks because of fallout and their natural lashes falling out and needing to be replaced. So those patients are the ones, in my experience, I've seen a lot of really bad blepharitis, but it's not usually right away. um, I have to laugh because the one lady came in, her eyelids were swollen, super bad blepharitis, and I said, I think it's because of you. I think it's because of your long history of wearing eyelash extensions. But it's exactly the same conversation you have with that contact lens wearer that's wearing like a monthly lens and abusing a monthly lens, and they say like, "Well, I've been doing this for 10 years," and then you say like, "Well, that's why it's probably happening now." This woman was like, "Well, I've been doing this for 2 years now. Why now?" And I'm thinking, why? I mean,
Thank goodness it's only now and not when you first started, right? You got 2 years of good wear out of this. Be happy.
yeah.
This episode of To The Point is sponsored by Tarsus. Tarsus Pharmaceuticals applies proven science and new technology to revolutionize treatment for patients, starting with eye care. Tarsus is advancing its pipeline to address several diseases with high unmet need across a range of therapeutic categories, including eye care, dermatology, and infectious disease prevention. Tarsus is proud to announce that Xdemvy Lotilaner Ophthalmic Solution 0.25% is now available to prescribe.
So I do think some of the hypochlorite cleansers are probably compatible with the glues. I definitely think what We Love Eyes has is compatible with the glues. What I actually have had some patients tell me is that certain teardrops aren't. So some of the eye drops, when they're using them for dry eye, actually breaks the bonds of the glue, and they were noticing that more of them were falling out. So that might be another area where we could try to improve upon for these patients, because I don't think the trend is going away.
Yeah, now I remember my first patient with false lashes, and it was probably in school, but I was worried about GPC because, again, it's one of those patients that was wearing a lens for like 3 to 4 months. And I went to flip her eyelid, and I pulled out probably 8 lashes trying to avert the eyelid. And she was like, "Do you know how much that just cost you?" And I was like, "Sorry, ma'am. Like, here I am, 26-year-old Mark, fresh out of optometry school." It was either first year out or while I was in school. And I just remember being like pulling out lashes just left and right and like leaving them on a tissue in the exam lane, being like, here's your damage. But no, you need to quit abusing your contact lenses and take care of your eyelashes. Like, I think now for me, if a patient, no patient's asking me that, right? Like, as a male doctor, they don't, because they know the answer that I'm going to tell them, which is no, especially if you're having worsening dry eye symptoms. Like, all that you're doing is adding more insult to injury. So I use this analogy with contact lenses, but I think it works in this scenario, which is like when you want to put on eyelashes, like putting new shoes on a sprained ankle. Like, yeah, it looks good, and yeah, you can get by, but you're not going to get better until you fully fix the problem, right? So unless you really fix that ankle, everything that you do is just dressing. So we got to get to this. So if you want to address worsening dry eye, don't do anything that's going to make this worse, especially if it's cosmetic. Like, I get it. I do. Like, the contact lens person or contact lens abuser who has an ulcer that's a -10. You're like, listen, I would love for you to be able to wear a contact lens right now, but you can't. And so we have to have this ability to have that conversation with the patient that's still in a positive sense without making it feel like we're batting them on the hand or telling them, you can't have dessert with dinner, right? Like, it's just, we need to speak about it in a medical sense in a positive way. That's not like, oh, you can do whatever you want, but it still gives the patient the reason to trust you as their advisor when dealing with beauty products. Because when you don't do that, then they're going to stop telling you all the stuff that they're doing. And then it's going to end up causing more problems down the road, because everything that you throw at it, when we get all of these new drugs that's available and it doesn't work, it's not because the drugs don't work. It's because we're not identifying the real risk factors here.
Right. Which I think is a great call out. And I think the difference in those, maybe two scenarios is, would a patient actively ask Jackie, right? Thinking like, and not ask you, Mark, because she might think you don't know. So I think you taking that proactive approach is what.
Oh, I definitely don't know. But like, I will say, don't do
Well,
it.
I'm saying like maybe a patient would think, I don't know if I want to ask him because does he know or not? So I think that you taking the proactive stance with your patients is what is so important. And then they start to feel comfortable, asking you these questions because, we do have a lot of guidance for these patients to give. It's just that they, if we don't know their habits, like you're saying, how do you know what advice to give them? And then, you don't want to be telling people, don't do this, don't do that, if it doesn't even pertain to them.
Leslie, you and I were talking a little bit about like ingredients to avoid in makeup. And I don't know if this happens to you, but sometimes patients will say, oh, I use this. Well, first of all, you can usually tell if someone is using a lash growth serum, right? Like their lashes seem super long. Like the Rodin and Fields, I think, is a really very noticeable one. Like they are extremely long. So I'll usually say, like, do you use anything on your lashes, any serums or anything like that? And so sometimes we get in the conversation about lash serums, and I don't know all of the lash serums on the market. There's, I'm sure, a ton of them, but they'll sometimes I'll say, send me it. Send me what the thing is that you're using, like the ingredients. They'll be like, is this making my dry eye worse? And I'm like, probably, but I don't want to be so 100% sure. I don't even know what's in this thing. So they'll send me the list. And Leslie, do you have the list in front of you of all of the
Well, I mean, this isn't really all of them, but what Mark was also talking about with, just when you're trying to treat your dry eye patients and you're running into walls, lifestyle is such a big thing, whether it's nutrition or environment or cosmetics. And so this list in particular is coming from the latest TFAS work with their lifestyle workshop, which kind of really gets into the meat of all of these things. And really what I learned by working on the cosmetic committee is there's a lot of science that we need to gain in the area of ingredients. So there's maybe 20,000 different chemicals that go into cosmetics. And, the list is maybe 10 of, 10 of these that we know based on science we can tell our patients to avoid. But the prostaglandin analogs are definitely in that, whether they're what we're used to with bimatoprost, or if it's what's called synthetic prostaglandins, whatever's growing the lashes made it on that list, because there is some science, quite a bit of science around prostaglandin analogs and their impact on meibomian glands. Benzalkonium chloride, again, tops the list because we know there's a lot of harm to conjunctival and corneal tissues there. The most of them are preservatives like parabens, phenoxyethanol, chlorphescin, formaldehyde releasing compounds. Salicylic acid is something that's often in facial cleansers that was on their list. Tea tree oil still is getting, some negative press, if you will, on this list. And then retinoids, any kind of retinol. They are instructed not to put that right on the, within the orbital bone. But when you're thinking about relaxing fine lines and wrinkles, of course, instead of applying it once or twice a day, maybe all day looks good. And crow's feet really do go inside that orbital bone. So I'm sure our patients are not really even reading that label.
One of my staff members was asking about lash serum, right? Like, she was asking which one should she buy for her mom. She just posed it to other people, and the doctors, 3 of them are male, have no clue, right? Like, we have no clue what were like, hey, we used to sell Latisse in our office, we don't anymore. And she was like, is that a good idea? And like our first response was, right? Like it's like, we don't really have a great answer because all of the prostaglandins, it's like, yeah, it works, but like then you got to worry about all of these side effects that come with it. So do you want depigmented or pigmented areas around the eye? Do you think that there's a chance that her eye color might change? Do you want all of those sunken in orbit and preservatives on the surface? And it became this whole conversation that was just totally organic and totally just like, hey, I'm thinking about getting my mom this for Mother's Day. Just everybody talking in the office. So it was really interesting that this happened this week in preparation for Mother's Day, but we were able to get some guidance into some eye friendly glass growth serum.
I think for me, I have this list that I usually reference when someone sends me because I personally can't memorize all of these things. There's a lot of stuff on these, like, avoid ingredient list. I have a little sheet that I like use as my cheat sheet, but there are more natural ways that you can use, not even serums, but you can use castor oil to naturally lengthen the lashes that don't require any sort of, harsh chemicals that we're putting around the eyes. So I think it's helpful to give an alternative to a patient who's like the answer can't just be no, right? Like, okay, well, I'm really bothered by this. Like my lashes are really short. Like I am bothered by this cosmetic thing. And if you're going to tell me no, I'll just go somewhere else and just buy something online. So I think it's nice to have some alternatives for these patients that really do want something. But for me, the other thing about the ingredients list is if there is something that is less than 1%, like present at less than 1%, it doesn't even have to be listed on the packaging ingredient list too. So it's not even required to be listed by the FDA. So sometimes there's a lot of hidden stuff in there that you think like, oh, I guess these ingredients are maybe okay. Or it says something, innocuous like it's hypoallergenic, which really means nothing. So it's cosmetics can be hard to sort of tease that out, but I think it's really the point of this is really to start having the conversation with patients and let them know, oh, cosmetics do, I guess that makes sense, right? Like I think cosmetics would impact the eye. I think patients can understand that once you bring that up, you're literally placing it right around the eye.
Well, not to beat you up, Jackie, but in that TPAS report, they actually did call out castor oil might not be as benign as we thought. So worth the look.
Leslie, don't be such a
Well, I
downer,
would say
Leslie.
I would say my answer to some of those patients is thinning eyelashes could be a result of chronic blepharitis and meibomian gland dysfunction over your lifetime. So, it'd be like drinking soda and expecting to have all your teeth when you're 70.
But
Um,
there's water in soda, right? It's water is the
Leslie,
main
again,
ingredient in soda, just like sweet tea down here. It's like you need water, but the second ingredient is sugar, and the third ingredient is brown. That's what's in sweet tea. It's sugar, water, brown. That's what we
But I
drink.
do agree with you about the hidden ingredients. And I'll tell you the easiest one is if you see fragrance listed on anything, that is where the catch all is. So, fragrance is this word that they can sneak it on to any label and they don't really have to even say what's in that. And there's a lot of irritating chemicals that kind of get grouped in that. So, be on the lookout for that word.
I think it goes with just the general ocular surface in general, right? Like you can take so many things that you can apply to the eye and put it in other places around your skin and in your ear, but you can't take other medications for other places and put them in your eye. And that's because of the delicate nature of the tissue. And I think explaining that to patients, like I've seen people use eye drops in their ear and seen providers prescribe eye drops for the ear because they can be less expensive and they can cross and go that way. So I think it's just explaining that, like, listen, your eyes are super delicate. That's why you have all of these symptoms that are probably happening due to your dry eye disease. That's why it's important that you pay attention to what you're putting in and around your eyes and having that conversation again in a positive manner, but understanding that, hey, this is our domain. This is what we do every day.
Before we do a little final wrap up here, Mark, do you have any burning makeup questions that you think non-makeup users might want to know? You got any questions, or do you have any questions?
I mean, I always have questions. None of them are, they're all existential questions. But you touched on the word hypoallergenic, and I think it bears a little bit more lengthening as to why that term isn't necessarily as good as we think it is. And I think that's important because when we say get something that's hypoallergenic, like it says it on the label, but doesn't necessarily mean that it has anything to do with not causing an allergy or a response. Like, I think that's an important thing that we should hear as clinicians, because I think it's easy to just say, oh, get something hypoallergenic, but that doesn't really mean anything.
I think that's a great call out. It definitely does not mean anything in the over the counter beauty cosmetic world. Um, I think that we're also positioned now with a growing number of eye cosmetics, right? So you can start to guide patients towards some of these brands that we're seeing come into our space that are made for eyes. Jackie mentioned We Love Eyes. I think that we know about Eyes Are the Story, and then 2020 Beauty. And I'm not sure if any other ones have come in recently, but these are made with eyes in mind by people who have some kind of history in eye care. So that's another thing that's made it a little easier when you're trying not to say no, and you can say do better, and now you can offer up different things that are better. And for some of our patients, that's really made a big impact for them.
And then you mentioned the TFOS and the lifestyle report that came out earlier this month. Do you want to give a plug as to where people can find that as a resource? Because I think that, again, the more knowledge we have, the better we can do, especially with this, because it is the first step in every algorithm for treatment is lifestyle modifications, right? How can we adjust lifestyle instead of starting with prescription medications, right? So how can we find the easiest place to start, which sometimes is the hardest place to start, because then we got to dive into daily routines and exactly what we're doing and when we're doing it.
Well, they do a great job of summarizing, and sometimes even have a patient-facing handout that you can give on this lifestyle to save a little bit or save quite a bit of your chair time. So, tearfilm.org is where you can find all of that great information.
Great. Mark, thank you so much for coming on the podcast to talk about your favorite topic, makeup, and teaching us how you talk to your patients about that. It's been great having you here. Thanks so much for joining us.
Oh, it's been such a pleasure being with y'all. It's so lovely to see your faces, and so lovely to listen and talk to the void, right? That's out there in the world. So, um, I think it's important. One thing that I've been saying recently, there's a couple of things, but one, I just always like to say this: patients don't know what they don't know, and I think that's something that's important for us as eye care experts, that patients come into day in and day out, to know that they don't know these things, right? Like everything that we've discussed, we don't know that they don't know them, and we need to do our best thing to educate as much as possible. And the word chair time, that everybody thinks is so negative, like it's such an investment in the future of this patient, right? Like we get maybe 20 minutes with a patient if we're lucky, unless you're Jackie and you can book off like every half hour to 45 minutes for your patients and you can have plenty of chat time.
I knew
But
you were
like
going to
I
say
get,
that about me. I knew it.
yeah, I'm jealous, right? Like I get 20 minutes with my patients and I'm lucky if that's going to be all of their eye care for an entire year. So we have to pack in as much of that investment into making sure that our patients are taking care of their eyes between now and when we see them back, whether that's a year, if we're lucky, 14 or 16 months if they're a contact lens wearer, or even up to 3 years if they're a glasses wearer. So I think it's important for us to look at this chair time and asking these questions, not as a time sink, but really as an investment in the relationship that we have with our patients. Because I do think it's important that we develop this, because we are going to be the person that we want our patients to turn to for this education about what's safe and what's not safe. What's a good idea, what's not a good idea, what's going to be the best way for them to move forward with their eye care cosmetic experience. Because if we don't do that, someone else is going to, and I can guarantee you they don't have the background and expertise that we all have.
You're absolutely right. And I think that the investment in the patient is a great tip.
Solid ending, Mark. Way to go. That's why you're here. That's why we asked you to come. Way to go.
I'm always
And
here.
also just to make fun of Jackie for how much time she has with patients.
But that should be what we want, right? This is aspirational here. Like I don't want to feel like I don't have to rush through my exams, but like I want to be able to make sure that I can sit down and go through everything all at once. And I think that that's nice to have that, like, hey, I'm not going to get train wrecked or side railed by, a old optic atrophy that happened today, where I ended up an hour behind because this person showed up, no clue that they had optic atrophy with a 2+ APD. But this is what happens in primary care is like, I haven't had an eye exam in 5 years. Why is my vision bad?
Yeah, you're right. I think we covered a lot of stuff. We covered a lot of ground. Thank you, Mark, for being here. Always fun to have you.
Always fun to be around.
And now for the To The Point wrap-up. Dr. Schaeffer did a great job of explaining how he incorporates the conversation of cosmetic use with his patients every day. We know that cosmetic use, whether it's in the form of eye makeup products such as mascara, eyeliner, eyeshadow, or in facial lotions, facial creams, serums that are age-defying in nature, as well as makeup removers and facial cleansers, all of these have chemicals that can impact the ocular surface. So opening the line of communication is the first step in helping to better educate patients around these lifestyle choices when they pertain to dry eye disease. I think that Dr. Schaeffer really taught us how just asking the right question is the first step in helping your patient develop good habits and good hygiene habits for comfortable eyes and comfortable vision over the years.